Hello, my name's David Runciman, and this is Past, Present, Future, the History of Ideas podcast. We are coming to the end of this series of the history of bad ideas, and today I'm going to be talking to the neurologist Suzanne O'Sullivan about the problem of living in an age of diagnosis. This is not about medical diagnosis as itself a bad idea. It's clearly not a bad idea. It's often a good idea. Sometimes it's completely essential to get a medical diagnosis. The problem here is living at a time when there is so much diagnosis, when there are so many different kinds of diagnoses, when there is such a hunger for medical diagnosis. The bad idea here is over-diagnosis. Suzanne, I thought it might be helpful to start just to put a bit of a time frame on the phenomenon we're talking about, or rather I should say it's a range of phenomena. It's not one thing, it's a series of connected things to do with how medical diagnoses are arrived at, overdiagnosis, diagnosis creep, lots of different ways of describing it. Over the course of your medical career, is there a point where you would say you became aware of this? Is it possible to date when you started to worry about it?
So I think it has been as kind of a slow creeping phenomenon. But if I would say, when did I start becoming really concerned about it? I would say in the last 10 years or so, perhaps a little bit longer than that, maybe 15 years. So I qualified as a doctor in 1991. I've been a neurologist since 2004. And what has become extremely obvious to me over that time, so a lot of my patients are very young. So not children, I'm talking about people in late teens, 20s. And I have seen a growing number of people, especially in the last 10 to 15 years, who come to me with a long list of pre-existing diagnoses. And these are young people. 30 years ago, young people didn't have 10 diagnoses. They came to you with one problem and they got one or two diagnoses. So there's been a real trend in the sort of people presenting to me on more medications and with more specific diagnosis to explain different difficulties. And all of that would be fine. I wouldn't have a difficulty with that if the diagnosis was doing what it's supposed to do. So what's a diagnosis supposed to be for? Well, it's supposed to, in the first instance, explain a difficulty, but it shouldn't stop there. It should explain a difficulty and then lead to some sort of support or intervention that makes a person's life better. And that's where my real concern arose. I'm not only seeing younger people with more diagnoses, I'm seeing younger people with more diagnoses that aren't leading anywhere. And one diagnosis, if anything, just leads to another one. I don't see people's lives getting better. And that's why I became so sort of interested in and concerned about this topic.
And just one more time frame question. If this is something of the last 15 years, maybe the last 10 years, is it also something that you feel is rapidly accelerating? So, for instance, there are markers in this story. COVID is one. Post-COVID, would you say even once you first became aware of this, you have since become aware of almost an exponential growth in the phenomenon we're talking about?
I think the answer to that question depends on conditions. So I would say that I've really noticed the problem in the last 10 to 15 years, but the trend began in the 1990s or even earlier than that, the 70s, 80s, 90s. And then there was from the 90s, say, into just pre-pandemic, there was a steady rise in a lot of conditions. And I'm talking about things as various as, points in time, the change in a definition to what high blood pressure is. And suddenly there's a big peak in the number of people with high blood pressure or mental health conditions as they are gradually redescribed. So there was a sort of a gradual trajectory, but certainly for some conditions, and I would say that the neurodevelopmental conditions like ADHD and autism are the particular ones. There's been an exponential rise in those post-pandemic. So a steady rise at least since the 90s, and then for some conditions, a very abrupt rise post-pandemic.
We're going to go on and talk about, as it were, the patient side of this, the people who are getting these diagnoses, maybe who want these diagnoses and what it means for them. But as you also just said there, this is a story of definition and re-description. That's the word that you use. Descriptions are being re-described within the manuals like the DSM, Diagnostic and Statistical Manual of Mental Disorders, the best known psychiatric manual, but it's not just, this isn't just talking about psychiatric conditions. So this is also something that's coming, I don't know if this is the right term for it, but on the supply side as well as the consumer side. And I'm really curious as to how you explain that before we get on to what it means for the patients. What is going on within the scientific community, the medical community, that is creating the incentive not just to redescribe these conditions, but crucially to broaden, to widen the scope of these definitions? What's going on?
Yeah, so I would say that this began actually with doctors and scientists. I think, there's a real perception at the moment that people are desperate for a diagnosis, but I would say it began entirely within the scientific community. So since the 60s to a lesser extent, but certainly since the 70s, we decided that we would actively search for people who had the earliest possible signs of diseases or disorders, atypical things. So let's say prior to the 70s, you weren't diagnosed with cancer unless you had symptomatic cancer and went to your doctor and said, I've got a problem. But then sometime in the 70s, we said, hey, maybe if we looked for these people at an earlier stage and we sought out healthy people and screened them for cancers, we get these things earlier and we can save a lot of lives. And that obviously makes an awful lot of sense on the surface. And we've done exactly the same thing with multiple disorders. If you can prevent X number of strokes by treating blood pressure at this level, perhaps if we treat it at a slightly lower level, we can prevent even more strokes. And that's been a trend in medicine since, around the 70s. And periodically, a committee of experts will get together and redefine what hypertension is or change the way that we screen for cancers. And every time we do that, we find more people. And you can see how well-intentioned that is. It seems to be based on very good logic. Yeah, it makes sense. If I find earlier cancers, I will save more lives. Makes a lot of sense. We've done exactly the same with mental health disorders. You define a disorder like autism in the 1940s and say it looks like this. And then somebody comes along in the 1960s and said, you know what, I think I'm seeing this same thing in people who are substantially less disabled. I think there's a milder form. So you change the description. The difficulty we have in medicine is these are really well-intentioned changes, but we're not terribly great at following up the outcome of these kinds of changes. And we also have difficulty recognizing the point at which perhaps we should stop expanding criteria and stop lowering diagnostic criteria. And I think that's why we've got into the difficulty we have now is every time you change the definition of a medical disorder, you will find more people with that disorder. And if you stop by just counting those people and saying, oh, fantastic, I found lots more people, then you don't do the next stage, which is look at whether the population is benefiting from this change, then you run into difficulty.
So can we talk about some of those examples? As you say, part of this is simply about lowering the threshold. But there's also a change in language. So autism is the best known example of this, the move to reclassifying it as a spectrum disorder. What changes when a disorder becomes something that exists on a spectrum relative to something that is more, I think the word would be discrete than that?
So if we think about how autism changed in the 1940s, it was described as sort of extreme autistic aloneness. It affected people with learning disabilities. It affected language to such a degree that people with autism then had no language at all or very severe communication problems that nobody would mistake for normal per se. And then in the 1960s, somebody says, well, perhaps some of people with autism have similar difficulties, but they don't have a learning disability. So now you have made a diagnosis available to a new group of people, people with milder social communication difficulties and no learning problem. But then that continues, and herein lies the problem, is that we start off by saying in order to have autism, you must be diagnosed in infancy. So you must be very young when you're diagnosed. And someone says, well, maybe that's a bit, we're missing some people that way. So let's diagnose before the age of 3. And then somebody else, a group or committee says, well, before the age of 5. And then somebody else says, well, maybe the difficulties don't become obvious until you're challenged by secondary school. So let's say that you can have the diagnosis. We assume it was there in childhood, but you might not see it until someone is in secondary school. And with every one of these changes, you are inviting new people into the diagnostic group. And you're doing this for good reason. You believe that every new person you invite into the group will benefit as much as the original people in the group.
And then when it becomes a spectrum, is part of the problem here that the edges are almost not the focus of this anymore, and the space between the edges is so large that it can almost, not quite, but almost accommodate anything?
Well, if you go too far, as is I would suggest the case for autism, then you've expanded the diagnostic criteria so far that the new people being diagnosed look nothing at all like the original people being diagnosed. So if you take examples of people like Anthony Hopkins, the actor, has said that he has been diagnosed with autism. Elon Musk is apparently diagnosed with autism. So you've got these people, very high functioning, no apparent inability to communicate, and they have a diagnosis of autism. Compare them to the original group with autism, who still exist in large numbers, which are completely nonverbal people who could not survive in society without 24-hour care. And now you have a problem, because you try to research these two groups of people, high functioning people working with families, with relationships, and you are including them in research along with nonverbal learning disabled people. You will neither develop appropriate treatment strategies that help those groups. You will not find anything in their brains in common. When you go too wide with the spectrum, you include people who probably don't have the same problem.
ADHD is another one. Maybe it's the one that people are most conscious of now. There's been a real explosion in that. And that is an example of something else that you mentioned there, which is a condition which was not just diagnosed early, but associated with early years, morphing into something that can be, and indeed is, described as a lifelong condition, so that you can have a late diagnosis. And I think I'm right in saying that ADHD was originally defined as something that would pass. Children who had it would grow out of it. And that is no longer the case.
Yeah, precisely that. It was, in the 1960s, it was described as kind of a hyperkinetic reaction of children. So it affected small children before the age of 5. And it was defined mostly by hyperactivity that was understood to dissipate and disappear in adolescence. And again, we have the same process. At some point down the line, someone said, you know what, I think there's a hyperactive form, but I think there's also an inattentive form. So now we've got people with attentional difficulties invited into the group. And exactly like for autism, the age restrictions have been gradually relaxed so that now the diagnosis can be made in adults. Now, when I was a younger doctor or a junior doctor, it didn't exist as a diagnosis in adults. I never met an adult with ADHD because the very hyperkinetic young children matured out of it and older adults didn't get diagnosis. Now it's quite commonplace.
One more example, and then I want to talk about the broader context for this. So I didn't know this until I read about it in your book, and I was fascinated by it. So I had thought of Lyme disease as something that was pretty clearly defined. And if you'd asked me what it was, I would have said it's a condition that comes from being bitten by a tick. I couldn't tell you what the tick was, but I assumed that there would be people who would know what the tick was and that it produces symptoms and that there's a test for it. It can be quite hard to test for. I think I knew that, and it could go undiagnosed for a long time because the symptoms might mimic other things. But past a certain point, you can say this is what a person has got. So the thing I didn't know was that there was something called chronic Lyme disease, where, as I understand it, you could have symptoms that do seem to mimic the symptoms of Lyme disease, but no actual evidence that the person, according to the traditional tests, has been bitten by this tick. How does that come about?
Right. So, what I need people to understand, and the reason that I included Lyme disease in the book is because I think there's a sort of a perception sometimes that you go to your doctor, you have a blood test, the blood test comes back and it says positive, you have the thing, negative, you don't have the thing. I spend the morning in the office looking through the blood tests of my patients, brain scan results, and so forth. And you almost never get a full range of tests back that say these are all completely normal, because we all look very different on the outside and we are equally different on the inside. And yet we kind of expect from these test results some sort of immediately easily interpretable positives and negatives and normals and not normals. In the case of Lyme disease, And for every blood test, actually, there's just a dozen caveats. You have to interpret blood test results in a context of the person. So let's say a person has lived their whole life in the New Forest. They probably have had a tick bite or two in the course of that, and Lyme disease exists in the New Forest. They might have been bitten as a child and then had a positive test, but actually just developed immunity, never actually got sick. So they could have a positive test. The things we test for in Lyme disease are proteins on the surface of the bacteria, but they're not specific to that bacteria. They are seen on other bacteria as well. So if someone is sick in some other way, you can get false positive tests. If you do the test at the wrong moment in time, when the immune reaction hasn't really started, you can have a false negative test. So I could go on and on about all the sort of caveats. This positive could be a false positive for this reason. This could be a false negative for that reason. Test results are very, very difficult to interpret, and they depend entirely on the clinical story. What is the chances this person had Lyme disease? Now, that creates an opportunity for misdiagnosis and overdiagnosis in almost any medical condition. And if we take Lyme disease as an example, there's a very characteristic disorder called acute Lyme disease, where you get a really distinctive rash and a flu-like illness in the context of being in a Lyme disease area. And that's usually quite easily diagnosable on the basis of the really typical symptoms. But Lyme disease also causes symptoms, that we all get: aches and pains, tiredness, skin rashes, swollen joints. These are ubiquitous human experiences, especially as we get older. And at any point in time, there will be a lot of people going to their doctor. Any GPs listening to this will certainly agree that, you see vast waves of people coming in saying, I'm tired all the time. I've got, aches and pains in my joints. I've gone to my doctor with knee pain, which from lack of exercise. But I mean, it's the experience of a 50-year-old, that's how it is. Now, some of us will just be told, well, you know what, do some exercise and lose some weight and you'll be fine. And we'll take that reassurance. But other people are desperate for a more specific explanation for their experience. And disorders like Lyme disease are incredibly available because the symptoms of Lyme disease are so various. They could be used to account for almost anything. And because, as I've said, these blood tests are so open to interpretation, how the lab does them, how I interpret the results. So if you've got a population of people desperate to understand why they don't feel well, and you have a medical disorder that causes a wide range of symptoms and has unreliable tests on which the diagnosis is based, well, then these two things can come together perfectly, and you can have a lot of people being diagnosed who don't have the disorder.
Including, you give the example in Australia where the tick isn't present, I think I'm right in saying. There are tens of thousands of people who have been diagnosed with Lyme disease, and very few of them have been to a Lyme disease tick-bearing area. So what is going on there? Is that social contagion? Is this something where once it starts, as it were, once the diagnosis becomes available, the question is not, is the tick available in this area? The question is the diagnosis available in this area? And then there's a sort of dance between patients and doctors where this thing can get out of hand.
That's precisely it, really. It's just, we have a lot of people suffering who don't have explanations. And as I'm sure people will realize, doctors can only give specific diagnoses for a limited range of things. So when you have people desperately looking for explanations, and then an explanation comes into the stratosphere that says, here's a reason that some people feel tired all the time, then that comes as a great relief to both patient and doctor. Imagine that you're a doctor and someone has come to you 10 times in the last year saying, I'm tired all the time, and you've done all those blood tests and everything keeps coming back as normal. And then suddenly you read a journal article that says, Lyme disease is on the rise, or the patient reads a news article that says Lyme disease on the rise. Then you have the potential for a very satisfying consultation between patient and doctor, where a new diagnosis has entered the discussion that potentially explains the problem. And patient and doctor, in a sense, this is a collusion that allows both to come away satisfied because they think they found an explanation. to such a degree that in the States, where they monitor the number of people with Lyme disease quite closely, the number of positive Lyme disease tests every year, and therefore technically the number of people with Lyme disease is about 60,000, but about 500,000 people are being treated for Lyme disease, and therefore these are people who did not test positive. So the rates of overdiagnosis of Lyme disease are in the region of about 85%.
When I was reading about this, I found myself thinking of something, I hope I'm not trivializing it here, which is analogous in the world that I come from, which is universities. I mean, there's a lot of overdiagnosis of mental health conditions in universities. I think that's fair to say too, including self-diagnosis, which we'll come on to. But I'm not thinking of that. I'm thinking about something else, which is a phenomenon of the last 15, 20 years, which is grade inflation. And it's a similar thing, which is the expansion of categories to accommodate more and more people. And my colleagues and I used to talk about it a lot, very conscious of it. And some of the people I work with thought it wasn't a problem at all. It was a reflection of the fact that the students are harder working. They would say, and our teaching is getting better. We're more professional. There are fewer wastrels here. That's why we don't fail anyone anymore. But we've doubled the number of people who get first class degrees. And that's because they're twice as good as they used to be. And I'm a skeptic. So I would not buy that argument. And yet I was complicit because I was conscious year on year that I was giving more and more high marks. And I think it is similar in the sense that the problem was I would be aware that I was giving a higher mark than I would have done 5 years ago, but it seemed so mean to pick on this person and hold the line here. And the creep is really hard to resist. And I have a lot of sympathy, therefore. What made me think of it was you saying it's a satisfactory consultation on both sides, in the same way I feel good handing out a first class degree and the student feels good getting it in that instance, even though I'm aware in the long run, it's probably bad for both of us. So it's one of those problems which you can see it in the round, but in any given moment, you have to be very tough to resist it.
It's so much harder, and I don't think people really understand this. As a doctor, it is substantially harder to say sometimes you don't have the diagnosis, or I know you believe that this is the explanation for your problem. It's very difficult to say, but I don't believe that is the case, because it can be very upsetting to a person who feels that they have found the solution. But I think it's what happens in the long run. That's where we're falling short. So in a sense, maybe it's not a bad thing. If someone comes to me with tiredness and I'm not absolutely convinced they have Lyme disease, but they are, and I agree, I say, well, maybe you do. That would be fine if what happened next was that person then got the appropriate treatment and got better. But we're very bad in medicine at we love that moment of agreement where we both agree on the thing that we're not actually totally certain about, and we're very happy, but we're not very good at then following up what happens next. It's a little like the grade expansion you were talking about. If giving everyone a first class honor in their degree worked, we would have much happier, better adjusted, more employed young adults. We don't have that. And similarly, giving people overzealous diagnosis is a wonderful feeling for patient and doctor in the moment, but I think we're not very good at finding out what happens next.
I want to ask you about some of the other things that I think are assumed to lie behind this, and some of this may be true and some of it may not be true. I think a lot of people think that behind this is the pharmaceutical industry, particularly when it comes to mental health conditions. There are many, many more treatments potentially available, and many of these treatments are very lucrative for the people who produce them and manufacture them. It is possible to finely calibrate the sort of treatments that are available, multiple variants of the same drug. And that can lead quite quickly to a pretty cynical view that actually this is some of this, at least, however well-intentioned the doctors are, some of this is being sort of weaponized for profit. Do you think that's part of what's going on?
I'm much less hard on pharmaceutical industry as in their role in this than other people. So I'm not saying, of course, there's opportunists. There's private clinics, there's pharmaceutical companies, and they will quite happily capitalize on any sort of need or any kind of suffering. So I absolutely don't want to say that doesn't exist. But I really don't believe it was the original driving force. I think that, the opportunists like private clinics who are making overzealous diagnosis of ADHD, they just came in and capitalized on a problem that was created by more mainstream science, I would say, and by society and by culture. I think that we need to realize that something very well intentioned went wrong, which is that we thought if we diagnose more people, we could help more people, and we failed to do the long term follow up of those people. I think that we also need to turn a bit of a spotlight on ourselves in respectable mainstream scientists and mainstream doctors, because once you have a clinic for the thing and there's a bunch of PhD students researching the thing, and now there's a charity supporting people with the thing, and then basically the thing can't die, then it has to continue. And I think sometimes an awful lot of humility is needed in order to say, if I actually solve this problem, I'll solve myself out of a job, and I think that mainstream medicine's what it's gaining from perpetuating this phenomenon is part of what makes it very difficult to undo.
And there is an analogy there, even with my slightly trivial example of grade inflation, which is if you're the department that holds the line, if you're the group of people that hold the line, you actually get out-competed by the places that are willing to be more accommodating. You can almost talk yourself out of a job. This clearly also has something to do with technology in lots of different ways, actually. So if the time frame of this is 10, 15 years, but it began in the 60s and 70s. So there's a sort of slow burn and then a exponential increase. For instance, the example that you gave, it's become much easier. Indeed, it's become possible in a way it wasn't possible before to achieve all sorts of early diagnoses, but also to look for genetic markers, so things that might predict. So this isn't saying you've got the thing, but it's saying we've identified something that puts you within a range of the people who might at some future point get the thing. We could even put a number on that, though the number will be pretty vague. And the technological capacity to do that is expanding at an incredible rate. And that feels to me like something it would be almost impossible to hold that tide back. Technology, it doesn't have a mind of its own or a life of its own, but my God, it facilitates massive expansion of diagnosis.
Yeah, we're in a funny sort of place when it comes to technology now because, again, I qualified in 1991. You couldn't, no specific genes for specific diseases had been found then. We were only beginning to get MRI scans. So we only had, you could only do CT scans. The only way of looking inside the body was to do a CAT scan, which comes with loads of radiation. So you didn't do that on a healthy person. So we didn't know what the inside of a healthy person looked like. We've had very limited knowledge of genetics, and how these things have changed is just phenomenal. It took 13 years to sequence the first whole human genome, and that took place between 1990 and 2003. And we can now sequence a whole human genome in a few hours. So that technology has changed phenomenally. And that is going to be just the most amazing thing for future generations. But we're in a slightly funny place now because we can do this phenomenal thing. We can see a whole human genome, but we've never seen one before. And therefore, we don't exactly know what it means. And I don't think that people realize that. So let's say in the 1990s, when we first began to be able to do genetic tests looking for very specific disease genes, it took absolutely ages to do it. And we only did it, therefore, and understood the results in people who had a very strong likelihood of having something genetically abnormal with them. So you took somebody who had, 6 family members with cancer at a very young age, and you did genetic tests looking for a cancer gene in those people. Because we were having to restrict these tests to those kind of high-risk groups, we learned everything we know about genetics from those high-risk groups. But now what we're doing is we're doing genetic tests on people who are not high-risk groups, people who have no family history of cancer. We're drawing on our knowledge of a very specific limited group and assuming that similar sort of logic applies to a completely different group. And I don't think we can assume that at all because there is so much unknown about the genetic code and how to interpret it.
Is it, as you just suggested, we didn't know what a healthy person looked like because we had been studying people who had very clear symptoms of disease or ill health. But it's also that any healthy person will look unhealthy if you look close enough. I mean, it makes me think of there's a line in Gulliver's Travels when he travels to the lands of the giant people, where he more or less says, I'm told these people are beautiful, but they're not beautiful to me because I'm seeing them in such, huge dimensions. Human beauty, if you look at it close enough, ceases to be beauty. Is it the case that health ceases to look like health with this technology that allows us to look so far inside?
Yeah, I mean, essentially, you can find something that you would consider abnormal, per se, in everybody. So every human genome has millions of what we call variants, so just slight differences. But only a certain number of those variants matter one iota to your health. But we're really still going through the phase of figuring out which ones matter and which ones don't matter. And the difficulty with applying the same logic from people at high risk of a disease to people at low risk of a disease is all the unknowns. So, if you take, for example, a cancer gene, and since the 1990s, we've been studying cancer genes in people with a very strong family history of cancer. And based on that experience, knowing which variant you're dealing with and knowing the family history and knowing the type of cancer, you can create statistical predictions of what's the likelihood an individual with this variant, with this family history, with this kind of cancer will get cancer themselves. And then we apply that to somebody who's got no family history of cancer, and we think that that same variant means the same thing to them. But that doesn't allow for all the unknowns. And an unknown may be that there's loads and loads of people, millions of people out there with that cancer variant who don't get cancer because there is also a gene that protects against cancer that we haven't found yet. So we are extrapolating from a small group of high risk individuals to a huge group of low risk individuals and not taking into account all the unknowns in that new group. And as I said, when I'm doing tests on patients, especially as you get older, none of our brains, I mean, look at us on the outside, let's just say the brain is taking the same toll of aging as the outside of oneself. So when you do a scan, especially on an older person, you will 100% of times find something that's abnormal. But because we've never seen, I say this to students all the time, they look at scans and they'll say that's abnormal and make a big deal out of it. And I say, well, this person came in and they had gray hair and their face was wrinkled and they were wearing glasses. We didn't make a big thing out of all these kind of aging things. And these internal things are the same. But because we've been using these tests for such a short amount of time, the equivalent of the grey-haired, glasses-wearing, stooped person can sometimes be inflated in reports and turned into something that's important that isn't really important.
And as you said just then, this is partly about risk and probability and understanding those things. Some of the earlier examples of overdiagnosis are cases where there's a diagnosis and nothing much happens afterwards. But in these cases, sometimes there's a diagnosis and something very radical happens afterwards. There's very invasive surgery, for instance, life-changing surgery for people. If you are told as a patient, we've done a test and you are at risk of cancer, it's quite hard not to hear that as a call to action. And yet it doesn't have to be a call to action because it entirely depends what you think the balance of risk is. Do you think we, in this unfortunate space between the technology having this capability and our ability to interpret it right, we're actually misunderstanding risk as well?
So we still use the same language. If you have a mammogram, for example, and someone finds abnormal cells in your breast, we will call that cancer, and thereby making it seem like it's exactly the same thing as the cancer that I would have if I found a lump or I had a physical change that drew my attention to cancer. So I'm trying to make the distinction between a symptomatic abnormality that draws your attention to cancer and a screening test in a perfectly healthy person that suggests they might have cancer. Well, what happens is that, when you get the call back from your doctor in either of those scenarios, you'll be given exactly the same diagnosis. But these are not exactly the same things. If you have a symptomatic cancer, then the implication immediately by the fact that you could find it through symptoms is that it has grown. And if it has grown, it is a problem and you need it to be dealt with immediately. On the other hand, if you have abnormal cells found on a screening test and you are perfectly healthy, then there is no implication that that thing has grown. It may just exist and it could have existed for a long time and it may never grow. But people don't understand that. Again, we're back to this sort of we don't know what the inside of the healthy body looked like until we began searching for abnormalities and until we got technology that allowed us to find them. And then suddenly we discover, one study showed 45% of men in their 50s have abnormal cancerous looking cells in their prostate and 70% of men in their 60s have abnormal cells. That was the case 100 years ago, but we didn't look for them then and we didn't have the technology to find them. Now we are finding these things and we are calling them the same name and we are treating them with the same urgency. when they're not actually the same thing. And I really think the public needs to understand the difference so that when they get the call back from the screen that says, we found some abnormal cells, we think that they could be cancerous, that the person who gets that call understands that not every single abnormal cell grows and threatens life, and they have time to think and they can ask for more tests. What I would do in that scenario is say, well, can I have a repeat test in 3 months and see if it's changing? It's not automatically the case that you have to treat every abnormal cell in the same way that you would treat a symptomatic cancer.
And we do think that a diagnosis will introduce more clarity than existed before. I think that part of the reason people are hungry for a diagnosis is there is uncertainty, there is confusion, there is a feeling that you don't know what's going on, and then a diagnosis tells you where you are. But if you think about it in terms of risk, a diagnosis could introduce more uncertainty because value judgments have to be made. This has to be compared with this. The surgery has to be compared with the risk of the disease spreading. And there is no medical scientific manual that tells you how to do that. You can be guided, but it's a mixture of psychology, ethics, what you think the value of life is, what do you think the value of longevity is. And something about the language of diagnosis and the assumption that once you've been given the name of the thing, you are clearer where you stand. It's almost as if that's the thing that's got lost. You may be less clear where you stand.
I think it's important to kind of say that, a diagnosis is not a neutral thing or it's not a solely positive thing. There's a sort of perceptions that you get a diagnosis and the ideal situation, you get a diagnosis, you get a treatment, you get a cure. But at the very least, if something isn't curable, you have an explanation. And that's kind of where we stop thinking about it. We think, well, even if it isn't curable, now I know what's wrong with me. But people really don't appreciate that a diagnosis comes with a whole slew of harms. If we're talking about a physical diagnosis, like cancer found on screening, if you're unnecessarily treating a cancer that didn't really need to be treated, then you are potentially threatening the life of that person by giving them invasive, unnecessary treatment. And we can see that in studies. For example, there was a 2023 meta-analysis in the Journal of the American Medical Association that looked at all-cause mortality, so deaths of any cause in people screened for cancer. And you would expect that if you're finding earlier cancers, treating them and saving lives, that you would see an improvement in all-cause mortality. But actually, screening programs did not show any improvement in all-cause mortality for any cancer other than colon cancer, where there was an improvement of life was prolonged by 3 months. Now, what this means is that some people's lives were saved. Some people were found to have cancer. It was treated and their lives were saved. But some people fell prey to the harms of diagnosis. They got treatment they didn't need and that foreshortened their life in some way. So you're saving some lives and you're losing others. And I would say the same harm benefit ratio needs to be considered when we come to disorders like ADHD and autism as well. It's not a case of you get a diagnosis and it either doesn't help you at all or it helps you. It can be just neutral or good. It can be a negative thing too. So what happens to a 16-year-old child who has some communication difficulties, who's told that their communication problems are due to a brain disorder called autism? Well, potentially that can impact how they are treated by others. It can impact their expectations of themselves and others' expectations of them. It can affect their kind of identity going forward. If you believe you can't do something because your brain is not built to do it, how do you mature out of that difficulty? So I think this is a real problem with diagnosis, is that and this is where it all went wrong, really. So I said that we did something very well intentioned in the 1970s. We began looking for earlier and earlier disorders, and then we got technology that made that easier. Where it all went wrong, I would say, is that we forgot that actually, when someone's very sick, diagnosis always benefits them. But at the milder end of the spectrum, we've got this harm-benefit ratio where the harm can actually outweigh the benefits.
The other aspect of technology that people listening to this, I'm sure, will be thinking of relates to something we touched on earlier, which is self-diagnosis. And the ability now that we have, well, it would have once been to Google it, now ask Claude or ChatGPT, list your symptoms, and you will be given a diagnosis. I imagine for almost any set, I don't think there's any set of symptoms which, if you put it out there, a diagnosis won't come back. And if it doesn't come back, you just tweak them a bit and you'll get one. So to what extent is this the thing that's fueling it? Or is that also a bit like the thought that it's the evil pharmaceutical companies? Is it a bit of a red herring? I think in the sort of folk understanding of this, a lot of people would say the real problem here is self-diagnosis, the sort of hunger of people to do it DIY diagnosis. Is that the real problem, or is that a sideshow?
It is a little bit of a sideshow, I would suggest. I'm not sure everyone would agree with me. I'm not saying, again, it's a bit like the pharmaceutical companies. I'm not saying it's not a problem. I'm not saying it doesn't exist as a problem. But if people's perception is that that 3 year long waiting list for kids with ADHD is just chock a block full of people who've got nothing wrong with them, who don't need any kind of support, I would suggest that they're wrong. I think certainly if you look at social media, and first of all, I should say that I think, self-diagnosis is just hugely inaccurate. It distills disorders down to single traits. So if you look on social media, you'll see, I'm not very good at making eye contact, therefore I must have this disorder, or I'm not very good at getting down to tasks, therefore I must have this disorder. But of course, we all have these traits. People who self-diagnose don't understand it's not just having the trait, it's having the trait to a certain degree of severity that causes impairment, and it comes with other traits. So it's a bit like going back to Lyme disease again. It's not good enough to have the positive blood test. You have to have all the typical symptoms, and the correct caveats must be understood. So self-diagnosis is hugely unreliable. And if you look on social media, more than 2/3 of the information is just complete nonsense. So I'm not a huge fan of self-diagnosis, but nor do I think it is really the problem that we're facing now. I think anyone working in CAMS, child and adolescent mental health services, people working as psychologists, psychiatrists, they're not seeing people in their clinics and saying, this person has nothing wrong with them, stop wasting my time. They're seeing people who have real difficulties. But at the moment, those real difficulties are being given specific labels that seem to be culturally effective at this point in time. At this point in time, if you're a depressed, anxious person who's struggling in the world, a way of expressing that distress and asking for help is through diagnoses like autism and ADHD. It shouldn't be seen to say a person is not suffering, but rather it is a current language of distress. And I think the self-diagnosis is just a thing that exists on social media that is more of a sideshow, as you say.
And the other thing that will happen if you go online to find out what you've got is you'll also be led quite quickly, and you touched on this earlier, to an advocacy group, not just a support group, not even just a community of people who might be sharing what you're going through so you can discuss it with them. But there is an awful lot of advocacy out there from people who, again, I agree with you. I think almost everything in this space is well-intentioned. There are some bad actors, but almost all of it is well-intentioned, as it is in the university space that I'm familiar with. There are very few people who are doing any of this out of malign motives. There will be well-intentioned people who will think it is their job to raise awareness, but also to make sure that the people who suffer from this thing are given every possible opportunity to become aware of all of the treatments that are available, or to discuss the ways in which they are being disadvantaged by the system. And that's new as well. I mean, that just didn't exist 20 years ago. You couldn't find these groups.
It is ironic, but I think awareness programs are making people worse instead of better. I'm not saying that awareness is never good, and that we have young men have higher suicide rates than ever before. We need people to be aware of these difficulties exist, but we also need to be really balanced in the message. And I think advocacy groups in particular, but even sort of official messages, can cause people to worry about things that they never needed to worry about. So there was an interesting study done by the Department of Education, I think it was a year or two ago, where they compared two cohorts of school-age teenagers, and they gave mental health awareness training to one group, and they didn't give any mental health awareness training to the other group. And then when they compared general well-being at 12 months, they found that the group who'd been given the mental health awareness training were actually less mentally well off than the group who didn't. So one of the risks with raising awareness type advocacy is that you make people think that ordinary things they shouldn't be worried about are worrying, and they encourage people to give medical labels and medical names to things. The other thing that really worries me about I know it's going to be difficult for people to hear, but I worry a great deal about support groups and the kind of groups people enter when they get a diagnosis. Because if you get a diagnosis that says, I cannot do this list of things, and here's a group that you can join of people who also cannot do these things, that will naturally reinforce your difficulties by focusing your attention on them. Also, if your support network is dependent upon you having a disorder, if your friends, if the people that you turn to when you have difficulties are a group that you know through having a disorder, well, then what happens if you get better from that disorder? So I think we need to be concerned about, advocacy groups that focus too much on things people cannot do and therefore inadvertently reinforce the things people cannot do.
Are there things that people can do to escape some of these traps? So I've seen a phrase, you were quoted in this article. It's an article published in the Sunday Times just the weekend before we were recording this conversation, which was specifically in relation to ADHD, but it was about what was called de-diagnosis, which is not a term I'd really come across before. But it was about some of the potential advantages, using examples of people who'd been through this, of essentially being told not to think that this label applies to you for people who had, for whatever reason, become trapped by the label. I mean, it's not a great word, de-diagnosis. It's quite an ugly term, but I get what it means. Is that something that we should be thinking more about?
I think we should really need to be prepared to reevaluate diagnosis. So I think we hear an awful lot about someone gets a diagnosis, they're struggling in school, they're given a diagnosis. It helps them to understand their difficulties better. Everyone feels a little bit better because they think now they know why that person has been having problems. Now, as I've said before, it should never stop there. That moment of relief when you get a diagnosis may not be very lasting. And that is my concern, is the story stops there too often. So I'm really encouraging people to ask themselves a little bit down the line, in just the same way you would if your doctor gave you a tablet for migraine and a year down the line you're taking the tablet and the migraine was just as bad. No sensible person would keep taking the tablet. So I want people to be prepared to reevaluate a diagnosis. And a year down the line, if your life is not palpably better in some meaningful way, if the only thing better about your life is that now you're part of a group who also have your disorder, but you're not flourishing in any more meaningful way, then I think you should think, well, is this diagnosis definitely benefiting me, or should I consider doing something differently? So it's really a matter of reevaluation. These are disorders for which there's no biological marker. Nobody can ever say you have it and you don't, because there is no natural cutoff. But what you can do is say, is the diagnosis working for me? Has it really made my life better? And if it hasn't, then you don't have to continue referring to yourself through that diagnosis.
Some of the most distressing examples that you write about in the book relate to, for instance, people with chronic Lyme disease. As you say, if you, a year down the line, were still getting the thing that you were taking the pill for, you would think there's something wrong with the pill or there's something wrong with the diagnosis. But in the case of chronic Lyme disease, the other alternative to say, I just haven't gone far enough in, I haven't gone deep enough in. So people who are taking huge doses of antibiotics, who are ramping up the treatment because the diagnosis has almost become this thing that it's impossible to escape from under it. So if you are still feeling awful and you think this is the explanation, it's as though the only thing you can do is to go deeper into the thing that may actually be the problem. And it's almost heartrending to read some of these cases.
So I deal a lot with people with psychosomatic conditions. So I'm a neurologist, and the bulk of my clinical practice, what I'm trained mostly to do is treat people for epilepsy. But because, in the region of a third of people, or it depends on the clinic, but let's say a third of people who go to an epilepsy clinic with seizures actually have a purely psychological cause for the seizures. A lot of my work, I deal with people with psychosomatic conditions. And these are people they fall into this trap of medicalization by, firstly, being people who need explanations. So I've got a headache, why do I have it? And then they fall into a trap that once you go to a doctor, they'll do a test that will find a little irregularity that leads to another test. And these are people who often misinterpret bodily signals. So if I'm walking up the stairs and my heart rate increases, I might say, well, I'm unfit. But somebody else might say, I've got a family history of heart disease. I hope that isn't a serious heart problem. So these are people who've fallen into a trap of having test after test after test. and nothing is getting anywhere. And it's exactly as you described with the patients with Lyme disease. Once they're invested in trying to find an explanation or in trying to find a solution through a particular pathway, breaking that pattern is phenomenally difficult. And that's one of the things I spend a lot of time doing in my clinical practice, and that I would encourage people to do with every type of diagnosis. Is I would say, okay, you've done it this way for 10 years. You've done every test you can think of. You've taken every tablet you can think of. And where has it got you? If it hasn't got you anywhere, can you just consider doing something slightly differently going forward and just seeing if that changes? Just break the pattern of the problem that you're in. But I do understand why, if you believe you have Lyme disease and you're seeing a very supportive doctor who says you have Lyme disease, and you're part of a community that has Lyme disease, and a doctor like me comes along and says, you know what, I don't think you have Lyme disease. I think perhaps there's a psychological explanation for this, to give up this non-stigmatized medical diagnosis for this very stigmatized medical diagnosis, to give up a diagnosis that's treated with tablets and replace it with a diagnosis that has perhaps more of a psychological treatment. I mean, these are big changes to ask people to make and very hard to do, I think.
I want to just ask you a couple more questions. So again, I think something that often comes up in this context is the thought that what's changed is a diagnosis is now often seen as a marker of identity. So not just a marker of illness, but a marker of identity. So examples that routinely given, people used to say, I am anxious, and now they say, I have anxiety. And if you say I have anxiety, you're not simply saying I have a condition, but you are giving a label to the person that you are. And this also feels like a pretty recent phenomenon, although I'm not sure it is completely recent. So if you think of the sort of historical context of this, we used to have other names for these things. People had melancholia, or they suffered from nerves, or whatever it was. It's just we didn't have tests, we didn't have manuals, we didn't have multiple different fine-grained diagnoses. But in a sense, people's health and their identity have always gone together. But do you think that is also something that is really accelerating? It's often associated with students and student life, and there are advantages to having certain diagnoses. You get special help, and it can be hard to turn that help down when it's readily available for self-diagnosis. But do you think the identity component in this is something new, or do you think it's almost part of the human condition? Our bodies are always letting us down. They're a mystery to us. If someone comes along and tells you this is the explanation, it's quite hard not to identify with it.
Yeah, I think it's always interesting, that when I speak to members of the public, and, often they think that, what's happening now is a completely new phenomenon, that everything that is going on now is because we have social media, etc. But I mean, you've given an example of melancholia. I could give the example of hysteria. These kind of outbreaks of explanations for the way people are suffering have always happened. They did not need social media. They did not need televisions or radios to happen. The only thing that's changed in the way we sort of explain our symptoms is how the stories spread. It used to be that, in Paris in the 1800s, there was an outbreak of hysteria, and it spread within Paris. Well, now with social media, it can spread directly from Paris to Australia. So the situation really now isn't that different. But I do think the identity thing is something that has slightly changed. Incorporating disorders into your identity, combined with this very scientific language that we have, makes things sound much more definite than they are. It really concerns me, I should say, that when people incorporate medical illnesses into their identity, it can be useful if it's done in a healthy way, because it allows people to engage with treatment. It allows people to accept a diagnosis and kind of engage with their medical professionals. But if you allow yourself to be engulfed by your identity, if it becomes an integral part of your identity to have the diagnosis, well, then you will become more symptomatic and it will reinforce your difficulties. I think the thing that's really changed is that now we think about brain scan abnormalities and genetic abnormalities. And when you give scientific names and associate scan abnormalities with disorders, it makes them feel much more real. So I think our technology might be feeding into the problem there.
And that goes back to where I want to end, which is to touch on what I said at the beginning. As you say, people sometimes think we've changed. Like this is a symptom, this phenomenon that we're talking about, of the way in which we're somehow different from people who went before. We're needier, we can't live without more reassurance or whatever it is. And like you, I don't think we have. I think human beings have always been pretty much the same. It reminds me a bit of when people think that the problem of what used to be called fake news, no one uses that phrase anymore, now gets called disinformation or whatever it is because we've changed. We're hungrier for this kind of stuff. We become more prurient. We become more gullible. No, human beings have always been prurient, always been gullible. The problem's not with us. It's on the supply side. We have these appetites. We have these motivations. We have these ways of dealing and coping with these things. But if you saturate us with the thing, then we're going to change. And this feels like something comparable to that. The thing that has changed, starting in the 60s, accelerating through the 90s, exponential from the 2010s, is the availability of the thing. Like the diagnoses are just available, just as the crappy news and the terrible websites are more available. It's not us.
If I go back to the 1990s when I started practicing, I saw exactly the same sort of patients with exactly the same sort of range of difficulties. The difference now is the array of different labels available to them and the array of different doctors willing to give them the labels, and also the array of tests. You came to me with a headache in 1991. You got a CAT scan, and if there was nothing on it, you got sent home. Now I could spend the next 5 years of your life finding new different types of scans to do. So I think people's need is now being met by improved technology and by also a culture for us to give medical labels to things. It's a kind of a respectable way to explain how you feel. But yeah, fundamentally, I don't think people have changed now.
Suzanne O'Sullivan's book is called The Age of Diagnosis. Are medical labels doing us more harm than good? We don't often plug books on this podcast, but this one really is highly recommended. We have got one more episode in our series of the history of bad ideas, and it is coming out tomorrow as a bonus on PPF Plus. So if you'd like to hear it, click on the link in our show description or go to ppfideas.com. It's with the geneticist and science writer Adam Rutherford, and we're going to be talking about what's wrong with genealogy. Why do we have such a hunger to find out where we come from, biologically, genetically, familially, and what are all the things that can go wrong when we do find that out? Next time in our regular slot, an episode that's connected to this series but isn't a part of it, and when you hear it, I think you'll understand why. I'm going to be talking to the forensic anthropologist Sue Black about what happens when forensics and forensic expertise is put on trial in a courtroom. That's next time. This has been Past, Present, Future.